Hello, my name is Lindsay Miller, and today I will be presenting a crisis management plan for Josh using the hybrid model of crisis intervention. This model provides a structured framework for assessing acute crisis, stabilizing the client, and implementing both immediate and longer-term interventions. In this presentation, I will review Josh's presenting symptoms, relevant psychosocial and biopsychosocial factors, my diagnostic impressions, the stage of change, and Josh's individualized service plan. The goal of this presentation is to demonstrate how crisis intervention can be used to address both immediate suicide risk and the underlying factors contributing, to Josh's distress. So, Josh presents with elevated suicide risk due to active suicidal ideation, a specific plan involving a firearm, and identification of a location where he intends to attempt suicide. The presence of a plan, means, and location significantly increases lethality and clinical concern. In addition to suicidality, Josh reports persistent depressive symptoms, including hopelessness, anger, social withdrawal, and insomnia. Josh also engages in daily alcohol and marijuana use, which likely worsens emotional dysregulation in his impulsivity. His statement that he is, quote, tired of living suggests severe hopelessness and limited future orientation, which are both strong predictors of suicide risk. So Josh's psychosocial history reveals several significant precipitating and contributing factors. Josh's father died when he was 15, which appears to have been a major turning point in his emotional functioning. Shortly after this loss, his mother remarried, which may have compounded his grief and contributed to feelings of abandonment or instability. Josh is also facing current legal stressors, including possible jail time, fines, and loss of inherited firearms, all of which intensify his distress. In addition, he reports family conflict, strained relationships, and disconnection from his previous spiritual beliefs, further reducing his current support system. So, using a biopsychosocial lens helps explain the complexity of Josh's crisis. Biologically, chronic sleep disturbance and his substance use likely contribute to his mood instability, poor impulse control, and emotional dysregulation. Psychologically, Josh demonstrates unresolved grief, persistent anger towards his father, hopelessness, and avoidance of painful emotions. Socially, he has withdrawn from supports, experiences conflict within the family system, and no longer participates in previously meaningful relationships or activities. Although limited, his protective factors include some family contact, attendance and engagement in counseling, and his ability to verbalize his emotional distress. So Josh's case formulation suggests that his unresolved grief, depressive symptoms, and substance misuse interact in a pattern that maintains his crisis state. His father's death likely disrupted his attachment security and his identity development during his adolescence. Because Josh has not adequately processed this loss, his grief remains unresolved and manifests as anger, depression, and hopelessness. His use of substances appears to function as an emotional avoidance, temporarily excusing numbing distress while preventing healthy processing. Over time, this avoidance reinforces hopelessness and contributes to worsening suicidal ideation. Access to firearms substantially elevates the lethality of this crisis. So the primary problem areas identified in Josh's case include suicidal ideation with access to lethal means, including a firearm or a gun, unresolved or complicated grief, substance misuse, family conflict, social withdrawal, and the spiritual distress he is experiencing. These domains reflect broad impairment across emotional, behavioral, relational, and existential functioning. While several areas require treatment, the immediate priority is suicide risk stabilization due to the life-threatening nature of his current presentation. So Josh's primary diagnosis would be major depressive disorder, a single episode, severe, without psychotic features. This diagnosis is supported by his depressed mood, hopelessness, fatigue, insomnia, social withdrawal, diminished functioning, and recurrent thoughts of death. Secondary diagnostic considerations include grief-related pathology, specifically persistent bereavement features contributing to emotional dysregulation and avoidance. He also meets criteria for alcohol use disorder and cannabis use disorder at a moderate severity level based on his daily use and functional impairment. Together, these diagnoses help explain the multifaceted nature of his presentation. In addition to the formal diagnoses, several Z codes are clinically relevant to Josh's case. These include the death of his father, family disruption related to his mother's remarriage, social isolation, and legal problems. While Z codes are not mental health diagnoses, they document contextual stressors that meaningfully contribute to Josh's current crisis and should be included in comprehensive case conceptualization and treatment planning. Josh appears to be in different stages of change depending on the presenting issue. Regarding suicidal ideation, he may be in the contemplation or preparation stage as he acknowledges distress, has considered action, and is participating in counseling, albeit ambivalently. However, in relation to grief work, he appears more consistent with pre-contemplation because he avoids discussing grief directly and relies on substances such as marijuana and alcohol to manage his painful emotions. Understanding the stage of change is important for tailoring interventions appropriately and meeting the client where they are. So the first prioritized treatment problem is suicidal ideation with the access to a gun. The overall treatment goal is for Josh to maintain safety and demonstrate reduced suicidal ideation within 4 weeks. Objectives include consistently reporting suicidal ideation severity during the sessions and developing a collaborative safety plan within 1 week. These objectives are measurable, behaviorally defined, and directly ties to the crisis stabilization for Josh. To address the suicidal ideation, I will administer the CSSRS at each session to monitor changes in risk. Cognitive behavioral therapy techniques will be used to challenge hopeless and distorted beliefs contributing to suicidality. Person-centered interventions such as empathy and unconditional positive regard will strengthen rapport and promote honest disclosure of suicidal thoughts. The Stanley Brown Safety Plan will be implemented to establish coping strategies and support contacts, while means restriction counseling will address firearm access. DBT distress tolerance skills will also be taught to improve emotional regulation during acute crises. The second prioritized treatment area is complicated or unresolved grief. Once immediate safety is established, treatment can focus more directly on grief processing. The overall goal is for Josh to increase emotional processing of grief and reduce avoidance behaviors within 8 weeks. Objectives include identifying grief-related emotions and completing structured grief processing activities to promote emotional awareness and meaning-making. So interventions for grief include person-centered reflection and empathy to facilitate emotional expression in a safe environment. Emotional focused therapy techniques will help Josh identify and differentiate emotions such as sadness, anger, guilt, and loss. Journaling assignments will support continued reflection between sessions. Narrative therapy interventions, such as writing a letter to his father, will allow Josh to process unresolved thoughts and emotions. Externalization techniques will help Josh separate his identity from his grief and anger, reducing over-identification with pain. Excuse me. In summary, Josh presents with significant suicide risk due to active suicidal ideation, a specific plan, and access to firearms. Immediate stabilization and safety planning are the highest priorities in treatment. However, long-term improvement will require addressing the underlying contributors to Josh's crisis, including the unresolved grief, the depressive symptoms, and substance abuse. An integrated treatment approach combining crisis intervention with longer-term therapy is indicated to reduce risk and promote sustained recovery. And thank you so much for listening to my presentation.